we're going to move on to what really now brings this to a pointy end, how all of this reform impacts on patient care. Professor Brian McCaughan, who's the board chair of both the CEC and the Agency for Clinical Innovation, I'm sure just about everyone in the room knows, a cardiothoracic surgeon from Royal Prince Alfred Hospital. Brian.
It's certainly always a pleasure to follow Captain Case-Mix. One can only imagine what happens if he talks quickly. But as he said, I am a surgeon. I'm a cardiothoracic surgeon, and I'm certainly not used to being told what to do or what to say. Thank you, Deb Hyland. I was given this topic, it's not mine, and many of you would have wondered about that in looking at it. This is not Brian's style, correct. However, the more I considered it, the more I thought about it, I thought I'd take the politician's approach in answering a question to Lee Sales on the 7:30 report. I'd say whatever I wanted to say, regardless of the topic. So here we go. Firstly, let me say that a bit like Duckett, these comments are purely my own and based on little and personal and have not been approved or endorsed in any form by the members of my board, some of whom are here, boards, or the chief executives of the ACI or CEC. If anyone's to be shot, Andrew, it's me. As we all know, funding reform per se does not improve patient care. We must develop and, most importantly, implement best practice models of care across the New South Wales health system. We must provide quality health care for the people of New South Wales across all the dimensions of care, some of which have been said but not defined today, of access, appropriateness, effectiveness, efficiency, safety and consumer involvement. And most important, we must address unwarranted clinical variation. If there are appropriate, flexible and transparent funding arrangements, then providing both the right incentives and disincentives in financial terms to provide, as the Minister said, our very brave Minister who is keen to address all these, to provide the right care in the right place at the right time, to which I'd add the first time. Then funding reform can, like information technology, be one of the enablers to achieve improved patient care. As with every other field of business, every other deal I've been involved with, both quality and efficiency are measures of their achievement. You don't have one without the other. So what does this all really mean? As Dr. Foley said, it cannot be just as simple as activity-based funding that Captain Case-Mix would have you believe. We must all remember that Case-Mix was introduced as a utilisation and efficiency tool, not a funding tool. I well remember the initial heady days on the Australian Case-Mix Clinical Committee when we developed the Australian National DRGs, and subsequent modifications have now passed into it being used as a funding mechanism and, as has been mentioned earlier, bought by other facilities. We're all familiar with uncapped Case-Mix-based funding and the wrong financial incentives provided in such a model. And I am concerned with what I've heard so far that some of that's still there. Reward for admission and doing something, do anything. Down in Victoria under Captain Case-Mix, you just thought of a reason to bring patients into hospital and do something to them to get rewarded. We require in New South Wales to learn from their errors and have a much more sophisticated, appropriate, flexible and transparent funding arrangements, because the correct financial incentive in many conditions should be to make it you don't admit the patient, because you get a safer, more effective and more efficient healthcare for that cohort of patients. I'm glad no other ministers are here from the New South Wales government, but it's a bit like transport. The more roads we build, the more cars will fill them. The more hospitals we build, the more patients will fill them. Integrated out-of-hospital care at all levels is the efficient, effective public transport system we see in many modern cities. Activity-based funding must not equate to admission-based funding. Let's take an example. Patients with chronic obstructive lung disease or emphysema are one of our frequent flying groups. In this slide, you see the popularity of admission for this condition in Australia, and particularly New South Wales, compared to other jurisdictions worldwide. I'm sure you'll agree that France, which is at the top there, is not known for its low incidence of smoking. And we clearly over-admit this group of patients in New South Wales. These are the differences across local health districts. Some of the variance is totally explicable. But in the great work done by the BHI, comparing hospitals, there was a 7-fold variation in admission rates for this condition, with the greatest variation being in metropolitan hospitals. This is unwarranted clinical variation, and it costs, both in terms of quality and resources. The ACI Respiratory Clinical Network some years ago developed a model of care demonstrating the effectiveness of out-of-hospital physical therapy, getting on a stationary bike, in greatly reducing the need for this admission for this group of patients. The hospitals who have implemented such a program should be funded on a non-admitted activity-based funding. Not only are the savings evident to the system, but the care and outcome is much improved for the patient, and this has been documented in many jurisdictions and publications. Another example of the ACI work comes from its brilliant musculoskeletal network. Of many programs they have or are developing, the osteoporotic refracture prevention program has been rigorously assessed both in clinical and financial terms. Identify the osteoporosis at the first fracture, treat the osteoporosis, and you see a great reduction in refracture rate, readmission rate, and extends the survival of those patients, a bit like appropriately treating a cancer. The economic analysis, and this is real data, on 3 local health districts in which it was modelled, that if this model of care was implemented across New South Wales, that on an indicative basis over 10 years, 250,000 bed days would be used for other patients, representing a notional saving of $238 million. Nearly 22,000 patient separations could be avoided, and about 242,000 refractures of previous admitted patients prevented. Nearly 150,000 patient readmissions within 28 days would be avoided. This is quality care. This is much more important than case mix care. The model of care has been described, and the tsunami that is coming demonstrated. A solution has been provided for the LHDs to consider. The economic analysis has described the cost of continuing business as usual, and demonstrating and implementing the model of care can reduce the cost for LHDs, and the effects can be seen in year 3 of the program. Epidemiological, clinical and economic information provides a comprehensive argument for consideration by all LHDs. What makes these projects possible, though, is undoubtedly collaboration and partnerships at all levels, particularly involving, as Stephen touched on, the interaction between managers and clinicians through the whole program. At ACI, there are example after example of clinical guidelines developed by clinicians, consumers, and increasingly managers. They represent the opportunity to provide the appropriate treatment appropriately at a lower unit cost. We've heard a lot about activity-based funding, and it has its strengths, particularly in procedurally driven DRGs. As we all know, the cost weights is determined by an averaging processes, and hence hospitals and LHDs with, for example, high-quality surgical units who function with consultant-led services, coordinated care, minimal surgical complications and sepsis, and hence have a much shorter length of stay, with minimal return to the operating theatre and the rare need for readmission, will benefit greatly from an average cost weight that includes units of very poor quality outcomes. This is one of the elements of unwarranted clinical variation that has been discussed and is part of a session this afternoon. It came to the fore in the IPART study of health. Yes, the group that determines our electricity charges and bus fares looked at health in comparing 5 hospitals on a like-to-like basis and looked at 11 diagnostic-related groups. There are many recommendations, as you can see from this slide, and time prevents reflection on all of these. Well, if Rohan couldn't say more about me, we're obviously very short of time. What's extremely important, though, is the observations of the people from the IPART study makes great reading when you read this. They saw a range of management and clinical practice across all the hospitals they saw, and there were several what they called no-brainers. These are not my words, it's theirs. They felt all hospitals could be improved from learning from each other, and that's certainly what we're learning through ACI and CEC. The thing that surprised them was that these differences came as a surprise to managers and clinicians. And the clinicians really did think what they were doing was appropriate, but as they observed the differences that they saw very clearly, they can't all be appropriate. In one particular example, they looked at the length of stay for DRGs. This shows the wide variation in length of stay in blue and the ratio of the highest and lowest. In one particular operation, the best performing hospital, the surgeon and hospital will remain nameless, which was not surprisingly the one doing the most cases, and it's a bit like what Stephen said about hip replacement, that unit had a length of stay less than half of the state average, less than half, with a lower return to operating theatre and a lower operative mortality. This hospital clearly and appropriate benefits from an average DRG payment, although I could say that department doesn't seem to get rewarded for that. One thing that flows from this is the decision to whether to do a particular operation in your hospital if it costs more and your outcomes are poorer compared to the hospital down the road. As in Germany, and it was mentioned by Mary that they bought the DRGs that I was involved in developing, they take the view that if it can be done cheaper down the road for better outcomes, why wouldn't you purchase them? And that shouldn't be a shock to us. We only have one liver transplant unit, one heart transplant unit, 2 burns unit. But this is one of the ways the Germans, in their methodical way, implemented the Australian DRGs, which they did purchase from us. We've got a similar dilemma in New South Wales at the moment, which ACI is heavily involved with the Cancer Institute, following some very responsible and critical analysis from David Carrow and his group at the Cancer Centre with respect to low-volume, high-resource procedures in esophageal pancreatic surgery. This graph shows the number of operations done per year by individual hospitals. Don't look too closely, it would only frighten you, where some hospitals might do a pancreatectomy once every other year. There are far too many institutions performing far too few pancreatectomies and esophagectomies, and there are others being studied currently. And the most important thing in looking at this is it has a definite clear volume effect on both short-term and long-term outcome, with a greater than 3-fold increase in mortality at those hospitals performing the minimal amount. You've got to ask, would you have your relative operated at that hospital? But this is background information. The ACI, in conjunction with its highly successful Surgical Services Task Force, in conjunction with the Cancer Institute, the LHDs, and most importantly, the involved clinicians, are working towards determining the appropriate number and sites where this surgery should be performed, and there was a further meeting of that group last night. But surely, Director General, we should not have a financial model that pays a hospital for known, documented, low-quality outcomes. As difficult as it appears to be for the Commonwealth to do, and I've been involved with IPA on this, as difficult as it is to appear to quantify, outcome-based funding must be an integral part of activity-based funding. We can't ignore the outcomes for the sake of WESAs or any other acronym. The quality of care across the system is also extremely important away from the DRG environment. The CEC has been involved with many quality programs. Time only allows me to highlight 2. Firstly, Bloodwatch. When I was a young doctor in white shorts, frightening thought as it may seem, Highland, we thought nothing of topping up the patient with a couple of units of blood. This will make you feel much, much better, dear. Little did we know that evidence would soon flow, showing that both the short-term and long-term outcomes for that patient were harmed by that strategy. Nothing like the dollar to focus the minds. Blood budgets were devolved to local health services in 2004, and we were able to more accurately quantify volume and cost of blood products in New South Wales. And more accurately, and this was the part of the CEC Bloodwatch program, so successfully rolled out by Cliff Hughes and his team from CEC. Since then, to show what you do if you take action instead of talking about it, here's the great reduction in the use of blood products over that time, both in the number of patients who get it and how much blood each patient who got blood got. And in this slide, it shows the potential savings annualised out in terms of blood utilisation and costs projected over a 10-year period. Clearly, we need to fund the appropriate mechanisms such that the right incentives and disincentives are there for the appropriate use of blood products. As in much of this work with CEC, it's a no-brainer. It's a win-win with both financial savings and better patient outcomes. The second line I'd like to touch on is, in fact, a joint ACI-CEC project, two great organisations I have the great pleasure of chairing the boards of. There is a lot of admissions for sepsis and it's got a high mortality. And the longer you wait, the longer in getting the antibiotics on board, the higher the mortality and the longer the length of stay. And it's interesting to note that the average cost of a sepsis episode in a DRG model is almost 4 times that of any other average episode of care. The CEC has implemented a program to get first antibiotics with suspicion of sepsis given in within an hour. You can see when the program started at your left end, and it's really pleasing not just to see the initial result, but that it has been sustained. This results in an average 2-day reduction in length of stay for these patients. And when annualised out over the next program, it shows the incredible impact on bed days in hospitals. Again, quality care at lower cost. So we have to look at these across all the local health districts. These examples lead to a further discussion of unwanted clinical variation across the system and its relation to funding reform. This is the definition being used by the Australian Quality Commission, and it clearly indicates it's a problem in the health service performance. By any measure, there is too much unwarranted clinical variation in terms of both process of care and outcomes of care across the system, and too much tolerance of it. I won't bore you with the various excuses we have when it's put up, but there's the conspiracy theory that it's all part of what the bureaucrats would say and do to us. There's the random theory, this is the old physician's model, it's all just part of the rich tapestry of clinical practice, Brian. It's the sicker, I've been told everything in the 25 years of clinical management jobs. The sicker theory, almost every local health district's used this one. Our patients are just much sicker than all the others. You've all got sick patients, that's what we treat. The money theory, we just don't have enough money to do it right. And finally, the saints and the royals, we just do it better and it costs more. None of these are true. We love caesarean section in New South Wales. In fact, between 1998 and 2008, we were the jurisdiction in the world with the highest increase rate of caesarean section in the world. I'm not an obstetrician. I don't know which one's right, but IPART would say all those countries can't be right with such variation. And when we look at it across local health districts, it varies, and that one highlighting differences in public and private. Hysterectomy rates vary across local health districts, even though it is interesting to note the overall reduction, but it's also interesting to note something must have happened down in Southern at some stage that women down there decided not to see their gynaecologist. I'll leave it at that. Myringotomy rates vary much across the local health districts. And to a casual observer, it appears that the people who actually need them don't get them. And if you look at the Aboriginal versus non-Aboriginal rate, it's even more so, as Stephen touched on. But it's not just process of care or operations. Here's the outcome of acute myocardial infarction across New South Wales hospitals, done so well by the ACI and looked at every way. There is a 5-fold variation in mortality following acute myocardial infarction. We don't let this down. In conjunction with the BHI, the ACI are working with the appropriate clinical groups and networks to look at the validity of these findings and where we go with it. And the clinicians are very involved in that in stroke as well. To minimise clinical variation, we've got to accept that there is a problem and what it costs. We must implement system-wide changes in model of care. And most importantly, and that I'll repeat, to every question you ask me, the solution is in timely, accurate and comparative data. for the clinicians and the managers. There will be a loss of clinical autonomy following this, and there must be effective governance between the managerial and clinical groups, and the real answers to it is a return to consultant-led, coordinated multidisciplinary care. Where do we go in the first aspects? We've got to apply economic analysis and modelling to funding and activity data. We should use the potential that funding reform provides to support the provision of care in the best setting and ensure we invest in the right services. We should collaborate with all the partners and support LHDs and Medicare locals in implementing and delivering. We need to plan for the future, but most importantly, we need to change from an attitude of everything solved by a new dollar to looking at things, to changing adequate resourcing, supporting by disinvestment in things that no longer work or are not effective, and in reinvestment in things that do. It remains my firm belief from observations over 25 years of clinical management positions and having the opportunities to see models of care elsewhere in the world that link financials rather than solely to activity are more successful in implementing integrated health systems. Even if you're not attracted to the wonderful model at Kaiser Mounty because it's in North America, it is well worth looking more locally at the impressive Canterbury model in New Zealand of integrating its health services across all components. I'm aware that some of our local health districts have been looking at their pathways model. Pathways, guidelines, call them what you will, they are critical in providing the way forward for patients to receive the best care at the lowest cost, no matter where they enter the healthcare system. We all feel the frustrations in the health system across boundaries at the interfaces. Commonwealth, state, inpatient, outpatient, GP specialists, public versus private, but no one faces it more than the poor punter attempting to access timely, appropriate care. It is our responsibility with funding reform to break down the artificial barriers rather than entrench them more deeply with further bureaucratic requirements. The way forward is clear to me. Accurately, timely, comparative information must be provided across the system in a highly transparent fashion, including public availability. This will drive the change. High quality healthcare in all its dimensions does not necessarily equate to high cost healthcare. Efficiency and savings provided by the right care in the right place at the right time, the first time, will provide the necessary funding. Thank you.